thought maybe you were just having a bad hair day and you just didn't want to.
Oh, that's every day. It's a bad, almost no hair left day.
This conference will now be recorded.
Okay, we're live streaming and you can begin the meeting.
Thank you, Ben. Thank you for joining us for the June 8th, 2021 Respiratory Care Advisory Council. I will now take attendance. Dr. Kakarala.
Present.
Amy Rodenhausen.
Present.
Karen May indicated she would not be here today. Robert Pelfrey.
Here.
And Cindy Groeninger.
I'm here. Cindy Groeninger's here.
The meeting is called to order. Then, since we have a quorum, let the record show that we are starting the meeting at 2:02. The meeting minutes from the September 2020 meeting were included in the information I sent you last week. Are there any questions about the minutes at all? Showing none, then could I get a motion to approve the minutes from the December 2020 meeting?
So moved, Dr. Cockrell.
Thank you, Dr. Tuckerella.
I'll second.
A second to that motion?
I'll second, Amy.
And then a voice vote. All those in favor of approving the minutes from the December 2020 meeting, state aye.
Aye. Aye.
All those opposed?
Aye.
Aye.
The minutes stand as approved. At this point, we were going to ask Chelsea Wonsky, who is our legislative director, to give an update that she is watching the Senate testimony, which would be one of my updates, which is the Senate is due to release their sub-bill today. And she is waiting anxiously, or maybe not anxiously, to see the amendments that they may be putting in the sub-bill today. And if there's anything that impacts the respiratory care community, that is something that we'll communicate back out. Also, the other update that she had, which is about the telehealth bill. There is a telehealth bill that did pass out of the House. It is in the Senate, and it has not had a first hearing in the Senate yet. Is there any questions around the legislative update? At our last meeting, we had a conversation regarding some rules that have been promulgated by the medical board, requesting to update the evaluation and treatment requirements for some of our licensees, including the respiratory care professionals. This proposal would change the requirement of a 72-hour inpatient evaluation cost $35.70 to an outpatient evaluation costing $800. This rule is still in process. However, I thought now would be a good time to ask Nelson Heiss, clinical director for the Ohio Physicians Healthcare Program, which is also our One Bite program. That's who administers it, to come and talk about how the medical board partners with OPHP and also the One Bite program that they run to help our licensees. Nelson, thank you for coming today. Are you ready?
Yeah, I'm ready. Do I, if I want to share the screen, is there a share button somewhere on there?
Benton, how does he share his screen?
Mr. Hallex, I will make you a presenter right now, and then you'll be able to share your screen. If you give me just a moment.
Not a problem.
Then while we're waiting,
And there.
Okay.
You
should be able to share your screen now.
All right. And let me bring that up then.
Brandy, I'll introduce you.
There we go. Yes.
So you see, I see that. Yep. All right. Let me get it.
Yes, we can see that. Thank you.
Yeah. Get the full presentation kind of going there. So, all right. Yeah. Thank you, Jill, so much for having me kind of get it on here and just talk a little bit about OPHP. We are, as Jill mentioned, we run the One Bite program for, I think we're contracted with the state, and the program's obviously connected with the medical board. And so we work with Jill and Stephanie pretty regularly as we're trying to navigate through this pretty much a new update of this law that changed, I think, in 2019. There had been a One Bite law since I think the mid 80s, but this new modification of it's just recent in the last 2 years, and it's now encompassing respiratory care therapists. So I think it was a good opportunity for me to kind of introduce myself, because I'm the person that if a respiratory care professional gets referred to us, I'm the one talking to them, so I can kind of explain the process and a little bit about what we do here at OPHP. Just to give you some background on us, we've been a nonprofit organization since the mid-90s and been working with healthcare professionals, since that point. But we've actually been around as some sort of organization, even like 20 years before that, as a voluntary organization group since the mid-1970s, when kind of PHPs were evolving throughout the states as ways for physicians to get access to help for substance use disorders. But we became a nonprofit in the mid-90s. We're led by a medical director. We have an executive director that kind of helps, kind of keeps us organized. And I'm the clinical director. I'm the person that watches over our clinical staff and the care that we're directly providing to our participants. And we work with, I think that's the next page we'll talk about who we work with. Work with 5 of the major healthcare boards and licensees in Ohio. Medical board obviously being one of them, dental board, vet board, chiropractic board, and vision board. Now, each one of those boards has different rules and policies in place about how they approach, their licensees when they're struggling with substance abuse or even mental health. So I'm going to spend most of the time talking about specifically what happens when we get a respiratory care professional, as it deals with the medical board and the one by law. So I'm just going to give you a little background that we do work with other regulatory boards outside of just the medical board. We have 3 primary programs. We have a confidential resource program, educational outreach, and the monitoring and advocacy. And that is the one that most people are, if they are familiar with us, as what we do directly. That's the stuff we do directly with clients and licensees. The confidential resources are just this idea that if a healthcare professional, we will talk and communicate with any licensees under any board to give them the best resource we can. Who has a confidential resource, if they're calling up, asking for help, and we get calls all the time. I got a family member that's, I think they're struggling with this or that, and start giving them resources about where could they go to get help, where to get treatment, explain in the case of the medical board, the one by law, if it's another regulatory board, the expectations of that board, what they would need to do to kind of get help, if they needed to see it confidentially, if they were getting, if they're dealing with the board, how to help them navigate that. We give them, if they have like a legal issue, give them to attorney resources, things like that. So we have this confidential resource that we build in that anybody can call, access, there's no cost, and we can we help navigate and provide services the best we can as resources for people to help navigate their situation. Our educational outreach programs are the stuff that we're kind of like this, but we go and typically reach out to most of the medical schools. I think we've hit, I've hit all of them in my time being in this position. That now some of them we do annually, some of them we don't do as we probably hit them every 2 or 3 years. Go to most of the PA schools. I've done some respiratory care schooling and programming as well. And we just go out and explain about the one by program, about substance use disorder. We talk about burnout, we talk about mental health disorders and access and ways to get help. So those are some of our educational outreach programs that we do. And then the final thing that we do is the monitoring and advocacy program. And that is when we have somebody that does need services and does need help. And let's say they are a respiratory care professional and they get referred to us by the medical board. We are the program that helps them find a place to get an evaluation done, to see if there is a need for substance use treatment. If there is, help them navigate getting the best treatment and helping them follow the treatment plan that's been prescribed. And we also work with them post-treatment to make sure that they're compliant to the aftercare expectations as they're written in the rules and the law for the one by program, as well as do the monitoring and overall kind of monitoring and drug screening, and make sure they go to the meetings and providing advocacy letters and support for that person as they're trying to establish and sustain their recovery. So now we'll talk about the specifics of the one by law as we kind of move further along, but that is the kind of the direct service we do, is usually helping them get into treatment and then helping them once they're getting ready to discharge. And we follow them throughout treatment, just kind of seeing how they're doing and updates and encouraging them, to obviously follow the treatment plan. But then when we really connect with them afterwards, when we get them to get to the next, the monitoring aspect of the one by program. Pretty simple why we think that it's important to have a confidential program. It's an ability for the person to kind of really be able to focus on the treatment of health, give a place where they don't have to be reported to a licensing board. I've talked to Jill and Stephanie enough to know that their goal is to address the issues that the board needs to address and not really get involved with people that have health issues, especially if they don't involve patient care, and to be able to give them access to a place to get help for that treatment. And so it's important to have an avenue, and most states do have an avenue of confidentiality. It's called the one by here in Ohio, but it's called other things in different states. So there's an avenue where people can get help without impacting their license. The success rate, because of the accountability of monitoring, is substantially high in the healthcare professional program, in PHP programs. I think we have a slide at the end that talks about how we're into the 90 percentile rate of people that come and seek treatment are still absent 5 years later under the monitoring program. So that speaks highly of how the program works, not only what we're doing, but also the treatment and the treatment centers that we work with and getting them the help and the accessibility that this law creates for people to get the help. And then, of course, they get therapeutic support along the way. Again, the negatives of that, right? If they do get, in trouble with the board, say they don't get treated and there isn't an avenue, and so they try to hide, somebody tries to hide their illness, a respiratory care professional tries to hide or keep it under wraps, and all of a sudden they show up to work one day impaired, alcohol, and it has an impact on patient care, that causes the issue where now they could get suspension or probation on their license because that addiction, without feeling they could get help, has now creeped in and caused consequences. So by having an avenue, it helps, limit that, the suspensions from happening. Again, when they get in trouble with the board, and I think it's a probation, and so it's not necessarily as, there's more of a formula to how that works to the program than, say, the one bite law, where there's much more, the way the law is written is just much more therapeutically driven. There's disciplinary action, obviously, is public. And, when we do this and there's a difference if somebody gets suspended and they do something that gets them in trouble, then rightfully gets, in trouble, like say they do diversion or something like that, they're out of work for quite a period of time as compared to if they were getting access to this confidential program because they knew it was there to get that help. It gives them the opportunity to maybe avoid being out of work as long, and they're being out of work not because they're suspended, because they're getting health care and they usually can still access things like their FMLA or disabilities and stuff like that. So, those are just some of the advantages of having this law in place and why it's so important to have these confidential programs, because it just gives people opportunities to get well without some of the other, potential ramifications happening. Because we just know that you're, as a board knows, it's a hectic job to try to, protect public safety. And so I think, knowing that there's an avenue where they can get their licenses to get help without having to get involved probably makes it eases their burden as well. Misconceptions about what happens when people come in here. We do some evaluations of treatment. It just depends on the board. We do some, mental health evaluation, things like that, but we don't do any of the evaluations for the one bite program. Those are specific 3-day evaluations, or in the case that Jill was alluding to earlier about potentially being 1-day evaluations for respiratory care professionals. Those are done as specifically defined one bite programs. We do provide resources there. We do provide some therapeutic support. We obviously provide confidential services, but we aren't a legal team. We don't provide legal advice. We don't do direct treatment. We don't do like the IOP program, the residential programs here. We do some counseling as services. We call it coaching, but we don't do like direct counseling where somebody come and gives their insurance card and bill that. All of our staff are licensed either mental health or addictions professionals, but we don't do like direct what you would think is going to a office and do counseling there. We're doing more kind of coaching and support, and it's all just kind of lumped into the monitoring services. And we don't discipline people's license. Our job with the one bite program is when we get a referral from the medical board, or if we get a referral that's separate from the medical board, is to determine, are they eligible for one bite, which I'll talk about the eligibility in a second. If they are, get them to follow the one bite path, get them the help they need, give them the support they need. And if they aren't eligible for whatever reason, is to allow the board to know that and then let the board take over what they need to do for that process. So, we don't suspend, we don't discipline, and we have direct and open communications with the board. I think monthly meetings. I know our executive director meets with Stephanie and Jill and talks about kind of the referrals we have going back and forth. So we make sure that everything's kind of staying, connected, and we're not missing anything, especially getting the people to help. And that's one of the reasons I think it's created the change for the possibility of getting the 1-day evaluations for the respiratory care professionals, because of this open communication. We've said, hey, we have all these respiratory care professionals getting referred to us, but they can't access these 3-day evaluations, which are usually close to, on average, about $4,000. So that's a lot of money for somebody, a respiratory care professional, to come up with, as compared to like the 1-day that's about $800, $900. And so we had that discussions, and it's been real positive to see that we get to a place where we're willing to be able to get access for more people to get the evaluations, and if they can access the one bite program. Because it's always hard for me to get somebody that says, hey, there's this program you could get help to, but it's unobtainable financially. And so they say, well, just send me back to the board and I'll just see what happens. I don't think that's what the board wants. I don't think that's what we want. And so we're finding ways to reduce that. I think that's to me, it's a really exciting opportunity to be able to get more people help, and to also be able to get more people to avoid having to, get in the entanglement with the board, because it is, as the board would know, it's a process at that point. There's steps to what happens with the board. Somebody gets involved with, board action. So an example, just kind of to talk a little bit more about the One Bite program. There's certain eligibility that makes somebody be eligible for the program. 3 things: the practitioner is impaired, meaning they have been diagnosed with a substance use disorder. So if they have that, that's why the evaluation is so important. Say I got a respiratory care professional sent my way because they had a DUI, 2 months ago, and they had a high BAL when they did that, and they call and they say, I'm not sure if I have a problem or not. We have to do the evaluation, and through the evaluation, if they get assessed that they do, and it helps them kind of understand why did they get this diagnosis, what's going on. They get a diagnosis established, and then they get recommended for a treatment plan. And so that to me is really important. So that's why that evaluation exists, is to determine if they have that substance use disorder. Then the next thing is, have they never been in the program prior? And if they haven't, they're eligible still. And if they've never been disciplined by the medical board for impairment. So as long as they meet those 3 criteria, which should be everybody on that first opportunity, they have a chance to get into the One Bite program and get the access to this help. The other requirements are they seek an evaluation at an approved provider. They have to, this is a big challenge for a lot of our respiratory care professionals, but I think it's an important thing, so they focus on the treatment. They have to self-suspend their license for 30 days and then not go back to work until they're determined ready to go back to work by the facilitator and our medical director at OPHP. So, that's the goal there is to, if they have a diagnosis, they're taking the time out to get well. And so they it's not a suspension that's a public record. It's just that they self-suspend, they agree themselves not to practice. And we work with the licensees. And we do lots of things with their work. I've called up tons of the supervisors and stuff like that saying this person needs help. What can we do to access disability? What can we do to access FMLA? What does the insurance cover for treatment? Those kind of things, so we can get people the help they need and to be able to have some sort of support while they're off getting treated at that period of time. They complete the treatment. They get, enrolled with us for monitoring. They do a minimum of 6 months of aftercare, with the One Bite provider, and then they stay monitored with us for the next 5 years under the guise of the One Bite rules. And so during that 5-year period, they're doing probably about 2 to 3 drug screens a month. They're going to 2 to 3 support group meetings a week. Like I said, they do the aftercare for the first 6 months, and we provide them therapeutic support and advocacy through that time. So say credentialing comes up on something, we provide letters to advocate. Yeah, they have to disclose they went to treatment on that credentialing form, which is separate from the One Bite law, and so if they have to disclose that, we provide letters to support them on that. And the big thing about the One Bite law that, that is important as it relates to the medical board is they do not have to disclose it on their renewal that they went to treatment, because it says on that application, the little caveat says if you follow basically, I think it's rule 4371. If you follow the guidelines of that, you don't have to say yes to your treatment. You can say no as long as you're in the One Bite program. So it allows the medical board doesn't even get involved in it, or is not even aware in most cases that the person's even seeking treatment, because they've done what they needed to do to stay confidential to the board. These are the folks that are accessible to the One Bite. So obviously, PAs, physicians, dietitians, AAs, respiratory therapists, acupuncturists, radiologist assistant, and genetic counselors. I know that just recently cosmetic therapists went, and there may be another one that's going off the list soon. That's kind of where we work with all the licensees under the board. And we recognize, I think massage therapists, that isn't identified on here. We also do massage therapists. We do recognize that there is a financial difference between physicians and say, there's a massage therapist. Physicians and say, a respiratory care professional. And that's one of the reasons why we are working so hard to make sure that the One Bite concept is there for everybody to get, but also make sure it's accessible for everybody to access. And that's been really exciting this last year or so, just working on the changes we need to make sure that everybody can get access to that confidential care. And a little bit about this is a couple years old. This has changed a little bit. I can tell you that we have gotten more respiratory care professional sources, other medical board licensees. That number has increased. I would say our highest percentage of people still here is physicians, and then kind of residents that would kind of fall under physicians as well. Students, we do have some students. We have respiratory care professionals. We've got a couple just kind of outlier licensees, dietitian, acupuncturists, those kind of things. There's our dental professionals, include dental hygienists and dentists, vets. The vet professionals include vets and vet techs. And then we have a few optometrists, chiropractors. And we do work with like nurses and licensed counselors and stuff like that. But it's a separate kind of independent thing that they're just seeking monitoring outside of like their licensing, where they're doing it for their own kind of self-care and wellness. Most of our referrals are for substance abuse. We do get about 17% for education. We have about 6% mental health, 4% behavioral, and 9% other things. And most of the resources that we get are self-referrals. That number, again, is a little bit skewed because in the last year, we've been getting a lot more referrals from the licensing boards. That 14% is actually higher. I can just tell you that in the last year, I would say close to half of our referrals are coming from the medical board when somebody renews and discloses something that had happened from the last time they renewed. And especially picked up a lot with the respiratory care professionals because you guys got swept under the medical board recently. And so a lot of those new renewals are stuff that may have been handled differently or now being handled under the medical board's processes. And now we're seeing a lot of those people show up at our doorstep. Again, just there's the number of confidential agreements we have. You can see most of the people that are with us have confidential agreements. And that since our 2014-2019 recovery rate of no relapses over the 5-year period is 92%. I will be honest with everybody and say this last year has been a challenge. This last year, we've seen more relapses. I have seen more relapses this year than I've seen the previous 7 years being at OPHP. And I've worked with physicians even the previous 13 years of my career at different facilities. And this has been a real difficult year for not just physicians. I've had respiratory care professionals struggle. I've had all the licensees I've worked with, particularly respiratory care physicians. I've had a lot more struggles than I've seen. And so I think we all recognize that. We all recognize this has been a very stressful, difficult year to navigate and get through. And so we continue to discuss even the process, what happens when people relapse and, avenues for them to seek help, depending on the circumstance that occurred in. So, I like that we have those dialogues. We talk about this as a disease and not some sort of moral weakness on people, because it is an illness and it affects as many healthcare professionals, as much as it does the general population. So, anyhow, I want to kind of give a brief overview. I know I didn't want to waste a lot of your time, but I want to be able to be open for questions. Again, I'm the clinical director and I'm Nelson. So if there are questions, please let me know.
I just wanted to say thank you very much for presenting this. It's good to know that this program exists. And my question to you is, from a respiratory care perspective, we do have students that apply for their limited permit to practice respiratory care. Does this encompass them as well?
That's a great question. And I think that is something, and I don't want to speak out of turn, Jill, but I know that is something that's being discussed with the medical board as allowing, there's a change that we're talking about adapting into the legislation that will allow PHP, which means the confidential one state coming to this state transfers, as well as students being able to have access to the one-bite program. Currently, the way the law is written, it doesn't encompass that, but we've all recognized that something needs to be modified. So I know that there's talk as there's legislative change kind of coming on the horizon. That will be one of those changes that students will be able to access that program even before they even have a license. Or if they seek help, they get the program, when they apply, they can share they're with us, and there'll be a rule policy in place that will allow them to get that license without having initial discipline or anything like that on it.
Okay, thank you.
Nelson, this is Robert. This is a great program. How is this information going to be pushed out to the RTs in Ohio?
All right. And there's been a lot of different discussions about how to do that. I think there's going to be something about when they license renewal, that might be something that there'll be like a snippet of information that everybody will have to watch a video on. I do know that we send out quarterly flyers out to all the licensees that, email flyers and newsletters, I think quarterly out to every licensee, but I don't know how much of that gets hit. I know that some people receive it because I get responses from it, but I don't know how many people go to the junk mails or just kind of delete it or whatever, but I know we do reach out to every licensee that way. Jill, is there other ways? I know it's on the website, both our website and the medical board's website.
Yeah, it's on your website, our website, and then also in every communication that we send out for our e-news, it's on the bottom. of links, that could be helpful to our licensees. And we do include it in several e-newsletters a year.
So I would tell you, it is an unknown entity that I go to hospitals and do one by presentations, and people have been practicing for 20, 30 years in Ohio and have never even heard about it. So, it's just one of those things that we think we work to get out there, work to get the message out there. It's one of those things I think people don't think about unless all of a sudden it's smacking them right in the face and like, what do I do about this? And I think it is important that people know that it exists so they don't have to be in that situation where they're just like trying to control something they can't control and don't know where to ask for help for.
Jill, the Ohio Society for Respiratory Care would be happy to help as far as getting the information out on our website. And I think probably when the rule changes to where we are in fact going to be giving a one-day evaluation, I think that would be a good time to bring it up and explain the program. But I do appreciate your presentation. It's been very helpful.
That would be great, Sue. The association, as well as respiratory care professionals across the state, always participate in our rules, in our public rule comments. And so we always look forward to getting their perspective as well. And that would be great, Sue, once the rules get passed, if you could help us get that out there, and then also maybe put a link to the OPHP onto your website as well. That would be very appreciative.
Okay. Thank you. We will.
Anybody else have any questions for Nelson while we're holding him hostage here today?
That's, I appreciate.
Nelson, this is good. I will go. I'm sorry, did somebody have something?
Oh, I just thank you very much. It was very informative. I appreciate it.
Well, thank you. Thank you for having me. I appreciate doing it. And I think it's important just because we get a lot of respiratory care professionals, and we certainly want them to be able to get access to this program like everybody else and know that it exists. And I know that it's so much new information. Probably when they got swept under the medical board, it's hard to know every little piece, and just to know that hopefully you'll be able to know that this exists and they can get that out, that message out to there. Hopefully that'll get more people to ask for help. We like it when people get a hold of us, and I think the board does too, before they even show up in front of as a referral from the board. So the more people we can get that way, I think the better.
And Nelson, if you don't mind, I'm going to send your presentation out to everyone. And that way, if they want to look at your website or they want to look at our website or see what's available right now for them to look at, then they will have that as well. And I appreciate the fact that you talked about a partnership with the board, because that's how we feel. And I know that's what Brandy's going to say when I introduce her as well, because I feel like we're all working for a common goal. And we very much enjoy working with you and Kelly Long. So thank you so much.
Well, thank you. Yes, it's been really a delight in the last, especially getting to know you and Stephanie over this last year. It's been really appreciated, and Brandy, of course, as well. So
that leads us up to Brandy Dorsey, who is my buddy, who is the Chief of Compliance for the Medical Board, and she's been with us maybe 6 months.
Yeah, almost 6 months.
6 months. And so I want to give her a few minutes to talk about what her compliance section does and how it interacts with OPHP and what she does actually for the board.
Excuse me. Thank you, Jill. So I am Chief of Compliance, and part of my role here is working with the various programs that assist our licensees with getting treatment for both confidential programs, such as the One Bite program and the confidential monitoring program. But we also, I also supervise our probation department. So those licensees who have had the board action and who are in our probation department. So we have one compliance officer, Angie Sturgeon, who works with all of our licensees who are supervised for board orders and agreements. So Angie is fantastic. She's been here for a number of years. She's a wealth of information. And she works specifically with those individuals and those orders. I have been working closely with Jill and with OPHP and Stephanie on working on building the relationship there, that so we can continue to push out information to our licensees about these programs and to improve them. So it's been a great last 6 months of being able to make some positive change in working with these programs.
Does anyone have any questions for Brandy? She's a great resource. So I wanted to let you know that we will be taking member appointments to the full board tomorrow. They'll be voting, so I'll be sending out an email later this week on that. And then I also wanted to touch base on some topics for the next meeting. And if anyone has anything they want to add to my list, my growing list here. And we also have to hear from Sue too. The topics for the next meeting, we're obviously welcoming the new members. Sue reminded me that we had not had a co-arc update recently, and we need to do that. I am working with staff to come up with a way to make this more substantive for you and get statistics around complaints, and actions taken, generally knowing that we can't give out specific information. And so that's something that I'll be doing between this meeting and the next, so that we have something and we give you the same information every time and update it so that we have a point of reference going forward. And around remote meetings, I had mentioned this to several of you individually, but they did have something. There was something in the Senate budget saying that meetings for the state could be continued remotely. Somebody took it out. So I'm not sure where that stands at this point, but we're still hoping to be able to do this remotely. But I will be in contact since we don't meet again until September to let you know for sure. Do you want Benton to share your screen so you can share that document that I sent to everyone, or?
If you'd like, that's fine. It's not a very exciting document. That's why I kind of sent it just for people to refer to if they haven't.
Whatever you want to do, that's fine.
Okay, I appreciate that. Jill and I spoke. Are you okay for me to go ahead? Okay. We spoke multiple times since the last meeting, concerned about the fact that we had about almost 900 respiratory care RCPs who had been licensed, who had not renewed as of March, April, May. We've talked several different times. And so finally, we asked the board if they could send us an actual list of the people, because we couldn't, without knowing who they were, we really couldn't figure out why we had that many. In reviewing that, I did send out late today, and Jill, I think, forwarded it to you. We looked at sort of the license numbers, and those numbers obviously are consecutive in a chronological order so that you can get a feel for how many years these people have been in the profession. So we looked at the numbers, and when we first were licensed in 1990, there were about 4,200 approximately people that were licensed in 1990. And when we looked at that group of the non-renewals, there were 220 in that group. So in looking at the actual names, many of us know these are a lot of the retirees. They may be people who have kept a license but haven't necessarily worked clinically. I'm retired myself. I have my license, but I do that because I lecture and I also am, writing and things like that. But there are, a large number of people in our profession who remain actively licensed that may not be a part of the workforce. Then we looked at the years as they went along here. And if you have my form in front of you, most of the years from 1991 being the first year that they were licensed through, let's say, 2004, we had, less than 5% each of those years are not renewing. So there's not really a large number in that population. But then after 2005, we see an increase in the number of licensees who have not renewed. And I just wanted to point out that actually, if you look at 2015 to 2019, based on when they were issued their first license, we have about 32% of this list are in that group, which is concerning to me. It may mean that these are people that have left the state. It may mean that they've left the profession. but this was pre-COVID. So this is not since COVID. This just looks like we've had, quite a few licensees come and go since 2015. So I just put this together as sort of for your review. I think we will take it back also to the OSRC to try to figure out what we think is going on. Whether people are just choosing to do something else. I know as a manager, for all the years I was in the field, I found that, as we started to employ a lot of the millennials, I had a lot of problems with them wanting to work anything but day shift in the days they wanted. I'm not trying to be, that stereotypical, but I'm just trying to say, is a profession that brings you typically into night shift to begin, is that something that the latest, grads are embracing, or is that something that's, something that they are not excited about? So, I'm just trying to say, it just seems like our latest grads are the ones that we're seeing here that aren't. And I don't know, Jill, if we're going to see any of those renew or not, but as of right now, this was the list, and it's the retirees is not a concern of mine, but the newer grads or the newer licensed. And this wouldn't include either, like I say, the COVID and the travelers and those that we would expect to come and go. So I guess I'm asking if anybody has any ideas or any comments.
I'm kind of surprised pre-COVID. I can see post-COVID that there might be still some confusion about the extension of the renewal, et cetera, but those that were pre is a little confusing as to why. I don't have any feedback, not that I haven't heard anything, but.
Yeah, that's what I was going to say. The same thing. That's the kind of most surprising statistic that, just with COVID, there's so many things you can take away from it, and what people choose to do or choose not to do during or certainly after kind of the aftermath of the pandemic. But this clearly was trending. It sounds like it was trending, before, kind of COVID stressed the entire system.
Right. I mean, it does reflect COVID. I shouldn't say that it doesn't. These are people who were licensed before COVID hit, but that could be why they're not renewing now post-COVID. You know what I'm saying?
Sure.
I don't know.
Or maybe it accelerated a small, what would have been a smaller trend, and it just amplified that.
Yeah.
And I really think that most of us saw that at our facilities, especially for the people that are close to retirement. They expedited their exits to not expose themselves to COVID. I had several at my facilities that actually retired early to avoid the whole pandemic.
Mm-hmm.
Yeah.
And I think part of that obviously was just all of the older people that were, most at risk in the beginning when we weren't sure exactly what we were dealing with. And
Any other comments? So I really appreciate, we've been sending out every week or every other week, the medical board has been sending out to the associations that represent, the licensees, how many there are left to renew before July 1st, hoping that they'll put it in a newsletter. We're also sending things out directly to licensees as well. But, asking for help, we certainly don't want to lose anyone, especially respiratory care professionals during the tail end of a pandemic. But Sue was the only association that I reached out to who actually got a list of the people and dug into it to see if she could find trends and then bring it before this board. So I very much appreciate her doing that. I think that makes a huge difference.
Well, I think a little information to at least try to see if we can come up with why.
Yeah. Yeah.
I have heard people, oh, I'm sorry.
Go ahead.
I've heard people say, where I've worked, the younger, like millennial, not to single people out, but just in general, that they didn't even know there was an organization. I mean, I don't understand why they didn't know, but I have heard that comment as well, saying that, there's an organization. So some of their engagement is maybe lack of knowledge, or they didn't know what the association could do for them. I'm not sure. I don't have an answer either.
Yeah.
Well, obviously, after, we're done here, if you think of anything, you can always email me, email Sue, anything like that. Also, if there's any things that you think we should be talking about during our next meeting, which is in September, other than the things I mentioned, let me know that as well.
Mm-hmm. Jill, also just for everyone who's on the call, we are going to be holding an educator manager recruitment seminar at the state meeting. It'll be sort of a luncheon early afternoon program, because we want to try to get educators and managers together to talk about some of these issues and see what we can do to improve recruitment and obviously retention. This is a retention issue more than a recruitment issue. And anyway, more information will come out about that, but we'll share it with the board as well.
Yeah, and we'll send that out as well.
Okay. Thank you.
Anything else for the good of the order? Our next meeting is September 7th. Hopefully, we won't even know remember what the pandemic was by the time we get to that. Especially the respiratory care people who need a whole lot of rest. Could I get a motion to adjourn?
So moved, Dr. Cockrell.
And a second?
I'll second.
Second.
And a voice vote of approval. All those who approve, say aye.
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 Anyone not want to go home and say nay?
This conference is no longer being recorded.
Everything. It was nice seeing you guys.
Thanks, everybody. Thanks, Joe.
Good seeing you. Thank
Bye.
Thanks, everyone.
Thanks, everybody.
Sorry, I was a little late.
That's okay. We're just happy you were here.
I tried. Thanks.